Dr. Lingling Du specializes in medical oncology at the Osher MD Anderson Cancer Center. She earned her medical degree from Peking University Health Center in China. She completed her internship and residency at the Cleveland Clinic Foundation. She completed fellowship in hematology oncology at WashU in St. Louis. She specializes in hematology oncology with a special interest in GI cancers, and also specializes in GI neuroendocrine tumors and rare types of tumors. She's board certified in internal medicine, hematology oncology, and we're very lucky to have her today to be speaking about novel targeted therapy for biliary tract cancers. Thank you, Dr. Du.
Good afternoon, everyone. Thank you so much for your time here. I'm a GI medical oncologist, so today I'm going to discuss novel targeted therapy for biliary tract cancers. Actually, it's one of the most exciting area right now. Here's my disclosure. Just a little bit of background. Advanced biliary tract cancer is a disease that is still, after all these years and decades, with very poor prognosis. It's almost as bad as advanced pancreatic cancer. In 2026, there's an estimated of 12,640 new cases and 4,590 deaths from it. So definitely a disease with very high mortality rate. Just for the overall patient population with advanced biliary tract cancer, what are we looking at? We're looking at, for these patients with our best frontline chemo immunotherapy combination, a median overall survival of 12.8 months. So a little bit over a year, and a response rate of 27%. How about second line after they progress on frontline treatment? With the ABC trial showing that the standard of care second line is FOLFOX, guess what the prognosis is with FOLFOX, median overall survival 6.2 months, with the second line treatment with a response rate of 5%. That's with second line. So definitely a disease with very, very grim prognosis. Fortunately, right now we find out that there are actually more and more targets with biliary tract cancers that we have targeted therapy for. And it's important to point out that for biliary tract cancer, although we all call them BTC or cholangiocarcinoma, it's actually a very heterogeneous group of disease. There's intrahepatic cholangiocarcinoma that starts from the bile ducts inside of the liver. There's extrahepatic cholangiocarcinoma that starts from bile duct outside of the liver. And there's also gallbladder cancer. Usually we think it's probably even more malignant than the other two. And then right now we have a lot of targets that we can potentially target. HER2 expression is definitely one of the largest targets that we have for biliary tract cancer. Some reports that gallbladder cancer may be more enriched with HER2 amplification. And then intrahepatic cholangiocarcinoma, they may be more enriched with FGFR2 fusion or alteration or IDH1 mutation. And in addition, we have BRAF V600E, we have rarely KRAS G12C, and rare mutations of NTRK fusion or RET mutation. And then we're going to go through all the targets and associated target therapy in the frequency of more common and go all the way down to less common. So first, HER2, probably our biggest target in biliary tract cancer. Depends on the literature. Some literature reports that up to 20% of biliary tract cancer are HER2 positive, and it's actually more common in patients with gallbladder cancer. We actually have a couple of regimens that we can use for patients with HER2 positive biliary tract cancer. One of them is a combination of a TKI and an antibody, tucatinib and trastuzumab. Tucatinib is an oral TKI that targets HER2. It works here intracellularly, and trastuzumab, we've been using it for like 30 years for breast cancer. It's a monoclonal antibody that targets the extracellular domain of HER2, so it works here. So one works here, one works here. In the phase 2 basket study, tucatinib combined with trastuzumab was tested in patients with HER2 positive advanced biliary tract cancer in the second line or beyond setting. Important to point out that in order to be eligible for the study, a patient needs to have received no prior HER2-directed therapy, so HER2 naive. And like the majority of phase 2 study, the primary endpoint is response rate. Let's see how it works. One thing I really like about this publication is they actually outline for each patient how did they find out the patient has HER2 positive disease. It's actually very important for our clinical practice. We can see that in some patients, they did IHC on the tumor. If it's 3+, it's HER2 positive. If it's 2+, they reflex to FISH, and positive means that they're HER2 positive. Also, there are also a lot of patients that did not do the IHC, but they did NGS, either tissue or blood, and that's how they found out patients are HER2 positive. I really think that this is what we should be doing. At Ochsner, when patients are diagnosed with biliary tract cancer, actually they all reflex to IHC testing, and when they have advanced disease, we'll do NGS and try not to miss any patient that with a possible target for us to use. And we can see for all the patients that are HER2 positive received tucatinib and trastuzumab, the overall response rate was 46%. And remember, for all the other patients, the response rate with second-line treatment was 5%, so this is amazing. And looking at all patients, the median progression-free survival is about 5 months or so, and the median overall survival was 15.5 months, which looks way much better compared to like 6 months with FOLFOX alone. And then another very promising drug that we're actually using right now is zanidatamab. It works differently. It's a bispecific monoclonal antibody that directly directed against 2 different domains of HER2. So here and here, targets 2 domains. It's a special drug. In the Horizon BTC-01 study, it's a phase 2 study that used zanidatamab in patients with advanced biliary tract cancer in the second-line or beyond setting. This trial, they have 2 cohorts. Cohort 1 is patients with HER2 positive, like IHC 2+ or 3+, and cohort 2 are IHC 0 or 1 positive, so basically not really HER2 positive patients, and the primary endpoint is looking at overall response rate for cohort 1. And if we would look at their results, for all patients in cohort 1, like HER2 positive, they observe a response rate of 41%, again, pretty high. Disease control rate 69%, so almost 70%, and the median progression-free survival was 5.5 months. But if you dive deeper into the data, you see that actually the response was seen in patients with IHC 3+, so true HER2-positive disease. They see a response rate of 52%, disease control rate 79%, so close to 80%, and the median progression-free survival 7.2 months. Regarding overall survival, looking at all patients, median overall survival was 15.5 months, but we can see that patients with IHC 3+ clearly did better. Median OS was 18 months, compared to 2+ was only at 5.2 months. So based on, right now, zanidatamab, we can use it in the second-line setting, and right now there's a phase 3, Horizon BTC-302 first-line trial is ongoing. Basically, they enroll patients with advanced HER2-positive biliary tract cancer. They randomize patient to the experimental arm, which combines zanidatamab with chemoimmunotherapy versus the control arm, which is standard of care, chemoimmunotherapy. And this trial is currently ongoing, and we also have this trial open at Ochsner as well, and actively enrolling patients. And the other big player in the HER2 market is the trastuzumab deruxtecan. We call it TDXD. It works differently. It's an antibody-drug conjugate consisting of an anti-HER2 monoclonal antibody that covalently linked to a topoisomerase 1 inhibitor cytotoxic payload. So when we give this medication, the antibody will get hooked up with HER2 protein and then got internalized into the tumor cells, leading to payload release. And after payload release, the topoisomerase 1 inhibitor will kill the cancer, leading to cancer cell death, and also there's penetration of released payload to neighbors, hopefully to kill neighboring effect to kill the neighboring cancer cells as well. In the basket trial, the Destiny Pan-Tumor02 phase 2 study, they give all patients with HER2-expressing solid tumors TDXD at 5.4 mg/kg every 3 weeks. All patients have HER2-positive disease, locally advanced or metastatic solid tumors, have received at least 1 prior systemic treatment. They actually, the interesting part is they do allow prior HER2-directed therapy. So this is different from other anti-HER2 regimen. And primary endpoint is response rate. If we look at the biliary tract cohort, there was a total of 41 patients with HER2-positive biliary tract cancer. We can see that the efficacy is really being observed in patients with HER2 3+ disease. So in HER2 3+, response rate was 56.3%, and the median progression-free survival in HER2 3+ was 7.4 months, and the median overall survival in HER2 3+ patient population was 12.4 months. Around the same time, there's another phase 2 study in Japan that they used TDXD same dose in patients with HER2-positive biliary tract cancer. And they actually enroll patients with HER2-positive or HER2-low because TDXD in breast cancer, it also works in HER2-low disease as well. Same treatment, TDXD 5.4 mg per kg every 3 weeks in the second-line setting, allow prior anti-HER2 regimen, and primary endpoint is response rate. It's a very small study. A total of 30 patients received treatment. 22 of them had HER2-positive disease, and in the HER2-positive group, response rate 36%, median progression-free survival 5 months, median overall survival 7.1 months. But again, it's a very small study, but we do have data to support the use of TDXD in patients with HER2-positive biliary tract cancer. And then the last one that we're going to talk about, the HER2 target therapy, is a chemo-free regimen, trastuzumab plus pertuzumab, which is a regimen that we also have been using for a long time in treating patients with breast cancer. Pertuzumab is a monoclonal antibody binding to extracellular subdomain 2 of HER2, inhibiting HER2 dimerization. So pertuzumab worked here, and trastuzumab worked here. In a phase 2 TAPR basket trial, they enrolled a total of 29 patients with biliary tract cancer with ERVB2 or 3 alterations, response rate 32%, median progression-free survival 11 weeks, median overall survival 30 weeks. So this is also on the NCCN guideline to treat patients with HER2-positive biliary tract cancer. In summary, we have several players for patients with HER2-positive disease. Tucatinib trastuzumab combination, response rate 46.7%, progression-free survival 5.5 months, median overall survival 15.5 months. Zanidatamab single agent in patients with IHC3+ HER2-positive disease, response rate 52%, median progression-free survival 7.2 months, median overall survival 18.1 months. TDXD, trastuzumab deruxtecan in IHC3+ disease, response rate 56%, median progression-free survival 7.4 months, and median overall survival 12.4 months. And lastly, chemo-free regimen, trastuzumab plus pertuzumab, response rate 32%, median progression-free survival 2.7 months, and median overall survival 7.5 months. It's also important to point out for trastuzumab deruxtecan, it actually can be used even after a patient has received prior anti-HER2 regimen. Then going down our list, the next one we're going to discuss is the FGFR2 fusion, which actually in intrahepatic cholangiocarcinoma, FGFR2 gene alteration was observed in 10 to 16% of patients with intrahepatic cholangiocarcinoma. So we definitely see it. I also have patients with FGFR2 fusion positive cholangiocarcinoma as well. We also have several players in the market. Pamigatinib is one of the first drugs that we know. It's a pan-FGFR inhibitor, inhibits FGFR1 through 3. In the phase 2 5202 trial, it's a single-arm study using pamigatinib in patients with FGFR-positive biliary tract cancer in the second-line and beyond setting. A total of 3 cohorts. The first cohort is really the target, FGFR2 fusions or rearrangement positive, and then cohort 2 is other FGFR alterations, and cohort 3 is no FGFR alterations. Of course, primary endpoint is looking at response rate in the targeted patient population, cohort 1. So what's their result for cohort 1? They see patients a response rate of 35.5%, median progression-free survival close to 7 months, and median overall survival 21 months. Again, we're talking about for all the other patients, second-line median overall survival 6 months. So this is almost 2 years, which looks pretty good. For all the pan-FGFR inhibitors, when we give it to patients, we do need to think about the most common side effect that almost everybody has is hyperphosphatemia. The phosphorus level come up really high, so it's not like you give people the drug, you see them in a month and recheck the phosphorus level. When I give patients this group of medication, I actually check phosphorus level every 3 to 4 days, and you can see the phosphorus levels start coming up very rapidly. Several years ago, there's a phase 3 5302 study, first-line trial combining pamigatinib with cisplatin gemcitabine that trying to see moving it to the frontline setting would it benefit patient. However, this trial was closed to accrual back in 2024 because there's a change in the standard of care frontline treatment. And the other drug that I use a lot is futibatinib. Futibatinib is an FGFR1 to 4 inhibitor, so again, pan-FGFR inhibitor. In the phase 2 Phoenix CCA2 trial, again, very similar design, single arm, used in second line of beyond setting, primary endpoint response rate, and they observe a response rate of 42%, median progression-free survival 9 months, and median overall survival 21.7 months. Most common side effects, similarly, hyperphosphatemia. We monitor patients very, very closely. And again, similarly, several years ago, there's this phase 3 frontline study combining futibatinib with cisplatin gemcitabine in frontline setting. They also stopped to accrue about 2 years ago. And the third one that we have good data on is erdafitinib. Erdafitinib, I personally used it over 10 years ago for patients with FGFR-positive bladder cancer. So it has other indications as well. It's a pan-FGFR inhibitor. In the phase 2 RETINA study, they used erdafitinib for patients with advanced solid tumors with FGFR alterations. A total of 217 patients, primary endpoint is response rate. Out of them, 31 patients had cholangiocarcinoma. And regarding the efficacy in cholangio cohort, response rate was 52%, disease control rate 97%. So disease control is actually quite high. And similarly, it caused hyperphosphatemia, stomatitis, diarrhea. For all patients, they reported median progression-free survival of 4 months and median overall survival 10 months. But later this year, they actually have a newer publication that reported they pulled all the 2 large trials that tested erdafitinib in patients with FGFR-positive cholangiocarcinoma, and they found that very similar response rate, disease control rate, and median progression-free survival 6.9 months and median overall survival 18 months. So erdafitinib is also on the NCCN guideline recommended for patients with FGFR2 fusion-positive cholangiocarcinoma. And most recently, at ASCO GI this year, like all the other we talked about was pan-FGFR inhibitor. At ASCO GI this year, they reported the efficacy on lirafugratinib, which is a different, highly selective FGFR2 inhibitor, and they tested in patients in the second-line setting for FGFR2 fusion-positive cholangiocarcinoma. And their efficacy data is quite impressive. The overall response rate was 46.5%, disease control rate 96.5%, median progression-free survival was close to a year at 11 months, and median overall survival was 22.8 months. So definitely very good efficacy data. And if we look at the waterfall plot, remember disease control is 96%, so almost all patients had a certain degree of tumor shrinkage. It looks very nice. And because it's selective FGFR2 inhibitor, it sounds like the toxicity profile is a little bit different compared to other pan-FGFR inhibitors. Like the other pan-FGFR inhibitors, we really worry about hyperphosphatemia. For this one, not that many hyperphosphatemia, but it seems to be different side effect. Like more people have stomatitis, Hanford syndrome, nail toxicity, and some people have retinal pigment epithelial detachment. That is not FDA approved yet, but it's very exciting data that they just reported at ASCO GI. So in summary, right now for FGFR inhibitors for biliary tract cancer, we have 4 that we have good data on. Pamigatinib, pan-FGFR inhibitor, response rate 35%, progression-free survival 6.9, median OS 21 months. Futibatinib, response rate 42%, median PFS 9 months, median overall survival 21.7 months. Erdafitinib, response rate 52%. For all solid tumor, median PFS 4.2, median OS 10.7, but for the cholangio, when they group all patients together, it's even better. And lirafugratinib, which is a newer medication that they just reported, selective FGFR2 inhibitor, response rate 46%, median progression-free survival 11.3 months, and median overall survival, again, close to 2 years, 22.8 months. And next, we're going to discuss a very special mutation, IDH1 mutation, which was observed in 13% of intrahepatic and 1% of extrahepatic cholangiocarcinoma. We do have an IDH1 inhibitor, avocitinib, in the phase 3 Clarity trial. They enroll patients with pretreated cholangiocarcinoma with IDH1 mutation, randomized to receive avocitinib versus placebo. They allow crossover at time of progression, and primary endpoints progression-free survival. Response rate was low, 2% with avocitinib, median progression-free survival 2.7 months versus 1.4 months with placebo. But after adjustment for crossover, they reported median overall survival of 10.3 months versus 5.1 months with placebo. So if our patient have an IDO1 mutation, definitely we should use advocacy in their treatment course. And next, we're going to talk about a mutation that all GI oncologists are very familiar with, BRAF V600E mutation. It's less common in biliary tract cancer. 5 to 7% of patients have BRAF V600E mutation. We do have a combination that has tumor-agnostic indication. Dabrafenib plus trametinib. Dabrafenib is a BRAF inhibitor, and trametinib is a MEK inhibitor. In the phase 2 ROLL study, they used dabrafenib plus trametinib in all patients with BRAF V600E mutated, all solid tumors. Primary endpoint is response rate. A total of 43 biliary tract cancer patients. Response rate was pretty high, 53%, with a median progression-free survival 7.5 months and median overall survival 13.5 months. And next, we're going to discuss a even more rare side effect, KRAS G12C mutation, which was only seen in 1% of patients with biliary tract cancer. We know that for pancreatic cancer, almost 90% of patients had some sort of KRAS mutations, right? But for bile duct cancer, it's actually less common. KRAS mutations probably seen in about 20 to 30% of patients. Extrahepatic cholangiocarcinoma, they may have more KRAS mutation, but it's less common in gallbladder cancer, intrahepatic cholangiocarcinoma. KRAS G12C mutation is very rare at 1%. Adagrasib is a KRAS G12C inhibitor. In the phase 2 CRYSTAL-1 study, they enroll all patients with KRAS G12C mutated advanced solid tumors and give them adagrasib, 600 milligram 2 times daily by mouth. Overall response rate is their primary endpoint. A total of 12 patients with biliary tract cancer. Response rate was observed at 41.7%, median progression-free survival 8.6 months, and median overall survival 15.1 months. So if our patients are lucky, have the KRAS G12C mutation, we should definitely try adagrasib. And lastly, we're going to go over two mutation that is very rare. One is NTRK, one is RET. It's really uncommon, less than 1%, but we do have tumor-agnostic indication for these medication. So one is entrectinib, which is oral TKI that targets multiple targets, TRK, ROS1, and ALK. In a pool analysis of 3 phase 1-2 studies, examined this medication, a total of 54 patients were treated with entrectinib, and only one had cholangiocarcinoma. This is the robust data that we have. And this patient, we can see here, achieved a partial response with progression-free survival of 12 months. So that's pretty good, keeping disease at bay for a year. And the other one is larotrectinib, which is also a kinase inhibitor targeting TRK. There's a study that was recently published. They're looking at larotrectinib in patients with TRK fusion positive GI cancer. Total of 44 patients, 4 of them had cholangiocarcinoma. For the non-colorectal cancer cohort, including 4 with cholangiocarcinoma, they observed a response rate of 6%, stable disease 44%, progressive disease in 22%, median progression-free survival 4 months, and median overall survival 9 months. So entrectinib and larotrectinib, these are 2 medications that we have for patients with NTRK mutated biliary tract cancer. And the last one was RET. It's very uncommon, less than 1%, but my colleague, Dr. Suma Sadi, just tested me 2 weeks ago saying that she is seeing a new cholangiocarcinoma patient, and the patient has a RET mutation. What should she do? So definitely it happens. We should check that. We also have 2 drugs, has a tumor-agnostic indication. One is prasitinib. It's a TKI that targets the RET kinase. In the phase 1-2 ARROW study, they treated a total of 23 patients in the efficacy group. 3 had cholangiocarcinoma. For all patients, response rate 57%, disease control rate 83%, progression-free survival 7 months, and overall survival 14 months. We can see these 3 cholangio patients that I highlighted out. This one, the one on the bottom was on it for maybe 5 months or so, not very long. This one on it for 11 months, almost a year. And this one is on it for almost 2 years. So that is pretty good for this patient. And the other drug is serpicatinib. It's also an oral TKI that targets the RET kinase. In the phase 1-2 libretto study, they treated a total of 45 patients. 2 had cholangiocarcinoma. For all patients, response rate 44%, disease control rate 77%, and median progression-free survival 13 months. So I don't know which one Dr. Sumasadi picked, but I think we definitely fully support the use of target therapy with a RET kinase inhibitor if the patient had the RET mutation. And lastly, I really want to focus and talk about the challenges of targeted therapy when we as providers are seeing and treating our patients. For me, it's really the resistance. If you think about all the data that we talked about, especially say for HER2, FGFR2, BRAF mutation, we don't really worry about the response rate. The response rate is so high. Disease control rate is almost 90, 96, 95%. We don't worry about we are having a good response. But in my personal experience, although they have a very good response in the beginning, very soon, they start, like within 2 or 3 months, we see the tumor markers start coming up, the cancer start growing. So that's my biggest problem when treating my patients with targeted therapy in cholangiocarcinoma. It's the very quick development of resistance. So this is a study that I found that is very interesting, that it looked at 77 patients treated with FGFR inhibitors for cholangiocarcinoma. They see that for these 77 patients, the overall response rate was 44%, disease control rate was 70%, so 30% of the patients actually progressed despite that they have an FGFR fusion. And the median progression-free survival was at 8.3 months. And they actually do a lot of the sequencing, DNA testing in patients like before and after progression. And in those after progression, they check the cell-free DNA, so they do have blood tests to look at the DNA. They found out that 65% of them actually had acquired resistance, actually have FGFR2 kinase domain mutations that make the patients, the tumor, not sensitive to the FGFR2 to the FGFR inhibitor. So that makes sense. And compared to patients with intrinsic resistance that they don't respond to begin with, only 10% of them had a mutation in the FGFR2 kinase domain. And they also reported the RAS mutation appeared in 13% of patients, with 78% of them rising concurrently with FGFR2 kinase domain mutations. However, if you look at it, 65% of patients had a mutation in this kinase domain. It makes sense. They don't respond to the FGFR inhibitor anymore. But 35% of patients had no detectable FGFR2 kinase domain mutation at progression. Then why did they develop resistance? We still don't know. So they actually recommend systemic analysis of off-target genetic resistance mechanism is needed. And they also think that, like they say, non-genetic factors, metabolic, transcriptomic, epigenetic, in acquired resistance warrant further investigation. And also, if you look at it, 30% of patients supposed to be responding to FGFR inhibitor, but not responding at all, they feel that intrinsic resistance is also an issue. Take-home points: novel targeted therapies demonstrate very promising efficacy in patients with advanced biliary tract cancer. The big targets that we have so far: HER2, FGFR2, IDH1, BRAF, V600E, KRAS G12C, and NTRK/RET. It really highlights testing is the most important thing. If we don't test, we never know that we can use these medications. To me, the most annoying problem for me right now is why did they develop resistance? Dynamics of molecular profile in patients on target therapy, how to delay the onset of resistance, and how to overcome intrinsic or acquired resistance is important. We know that for the phase 3 Breakwater study in BRAF mutated colorectal cancer, that we know that if we move BRAF target therapy to the front line and combine it with chemotherapy, adding chemotherapy can delay the onset of development of resistance to the BRAF targeted therapy. So I know that a lot of companies, they're actually trying to use the same strategy, like we discussed, moving the target therapy to frontline, combine it with chemotherapy to see if we can delay the onset of development resistance and further improve people's survival. But I also do feel that when we're doing this target therapy in the frontline setting, there's a lot of obstacles, right? A lot of challenges for us, such as a lot of times we may not be able to robustly enroll patients just because it's not very common targets, and sometimes patients are not treated at our institution, so we don't know they actually have these targets that we can randomize through the trial. We just discussed 2 frontline FGFR2 trials. They stopped enrollment because they just could not get that many patients on the trial. And that really highlights enrolling in clinical trials is the most important thing for almost all patients. That's how we continue to move the field forward and benefit our patients. And I'm happy to take questions. Thank you.
I have a question. Are you repeating NGS testing after you treat someone with a targeted therapy?
Yes, when they progress, I will. Like, especially I feel that GI cancer, say HER2 positive, definitely happen. Like it's HER2 positive, we treat patients with anti-HER2, and then very quickly they develop sometimes mutation in HER2 that made them resistant to anti-HER2.
I have a question. So if you have a biliary tract cancer with multiple targets, how do you choose? I mean, because the numbers seem to be pretty similar in terms of response rate, progression-free survival, median overall survival. There was a range, but they all seem to kind of lie within a similar range. How do you choose which one, assuming that they're FDA approved?
I'm not that lucky that I have more than one mutation. Like a lot of times if they're HER2 positive, I don't really see the other mutations. I don't know if they're mutually exclusive, may or may not be, but usually if we're lucky, we get one mutation. Okay, thank you all so much for your time.